Topic of the lecture today is autoimmune heart diseases. So what are autoimmune heart diseases? Autoimmune heart diseases are those diseases which come under the heading of body killing its own body. It means our own immune system is acting against our own cells. Our own body cells are being subjected to that kind of uh, effect of our own body, of our own immune system. So what happens is that our own immune system identifies our own antigens to kill, and it starts acting, and it leads to these diseases that we're going to talk about. First of all, let's talk about acute rheumatic heart diseases. Now, what is acute rheumatic heart disease? Acute rheumatic heart disease is a disease of children, is a disease of childhood, and it basically starts with streptococcal infection. 99% of the cases, it's going to be deep throat infection. It's going to be pharyngitis. Due to the pharyngitis, due to that effect of pharyngitis, what happens is that patient swallows those antigens somehow, because a deep throat infection, it can go inside. Once it gets inside, what it's going to do, that it's going to get the immune system to react to it. So what will happen? Immune system will react to it in two ways. Either the cytotoxic T cells will be activated, either the antibodies against the antigens will be produced. Now we will learn how these immune reactions will lead to the formation of acute rheumatic heart disease. But for acute rheumatic heart disease to develop, three things are required. Number one, streptococcal infection. Number two, when there's not much of compatibility between immune system and the host cells, when the own immune system tries to go after its own cells. Number three, you can guess that. Number three is that they have a delayed reaction. It must take 2 to 3 weeks, after which it's going to happen. So let's study about it. So this is acute rheumatic heart disease. This is the gross structure of the heart after the acute rheumatic heart disease. And this is how it looks like on the slide. We're going to discuss both of these. But before that, let's talk about the molecular pathogenesis of acute rheumatic heart disease. So what's happening at molecular level? Or what's the main pathogenesis of developing acute rheumatic heart disease? It's such a major disease. You keep hearing about it in the texts. Basically, it's a disease of childhood, but it can also develop in adults. Main age group that gets affected by this disease are 7 to 11-year-old boys or girls. They're most subjected to it. So what happens is, first of all, a person is going to get a group A streptococci into its throat. What's going to happen? Streptococcal pharyngitis. When streptococcal pharyngitis is happening, now look at these cells are going in. So what will happen? T cells activated by streptococcal antigens. I told you there will be two systems which will be activated. It will either be T cells, it will either be B cells, which form the antibodies to fight this kind of antigen. Now, B cells produce antistreptococcal antibodies. Now, B cells thought that it's better that we produce antibodies. Now, B cells produce antibodies, and those antibodies are stored in your life for the rest of your time. Now, those antibodies, whenever this antigen will come in again, those antibodies will get activated and finish it in one go. Now, it's beneficial on one end, but it's going to be non-beneficial in this case. Now the antibodies are produced. Now the T cells are activated. They will both try to kill it. Antibodies and T cells cross-react with antigen of cardiac sarcolemma and valvular glycopeptides. Now up till this point, it was only physiological phenomena. We were having all the benefits of our immune system. We were having all the plus of our immune system. The T cells got activated, B cells got activated. Now they're both going to kill the antigen. Okay, now antigen is dead. For that period of time, patient is better. Patient is uh, being fine day by day. Patient is fine now. But after 2 to 3 weeks, now this is the time period in which it develops. Now, in 2 to 3 weeks, what happens is that those antibodies which were produced and T cells, they cross react with antigen of cardiac sarcolemma and valvular glycopeptides. Now, antibodies and cytotoxic T cells, now their formation has been affected. Now their code has been affected. Now they are identifying cardiac sarcolemma and valvular glycopeptide as foreign material. And they are trying to attack these structures. Structures they were supposed to protect. Now they're trying to invade. They're trying to attack these systems. So what happens is that myocardial cells at this level, you can see myocardial cells will be affected, valvular glycopeptides will be affected, and when both of these systems, if B cells and T cells, antibodies and cytotoxic T cells, have made up their mind to affect these two cells, myocardial cells and valvular glycopeptides, what's going to happen? It will be myocarditis and valvulitis, meaning inflammation of the myocardium, inflammation of the valvula, all the valves. Now, if there's inflammation, what's going to happen? If the valves are inflamed, what's going to happen? It's going to lead to chronic rheumatic heart disease if not treated at this level. Now, up till this level, we had inflammation. Now, what's the effect of that inflammation? I ask you that what's the effect of inflammation of the valves? If the valves are inflamed, they're not doing their function. They're not opening and closing in a snap. We've learned that these valves open and close in a snap. They open, ventricles fill in, they close, they snap. Now, if they're inflamed, now they cannot do their function properly. Now, they cannot perform their function as they were supposed to perform. So, they won't be able to come like this. They won't be able to close in a snap. They'll come very slowly. Now, this opening and closing, now this is very difficult. They're inflamed. When something is inflamed, it's going to be subjected to more wear and tear by the blood. What about all the blood in the atrium that's going to go into the ventricle? What about all the blood in the ventricle which wants to go to the pulmonary arteries and aorta? Now they have a lot of pressure and heart is pushing them with the same pressure. But now if the valves are affected, now if the valves are inflamed, wear and tear mechanism will start right now. Wear and tear mechanism will affect it deeply and those areas will be subjected to more damage. When there's more damage, one way or another, it will go on and on and on, and patient won't recover, and it will lead to chronic rheumatic heart disease. Because we didn't intervene at that level. Now, repeated antigenic exposure may also lead to chronic rheumatic heart disease. For example, patient got better. Okay, patient is recovering. He is subjected to that antigen again. Now, the body will recognize it. Surely the body will recognize it. The body will kill the antigen, but it will produce more antibodies. It will produce more cytotoxic T cells against it. So more antibodies and more cytotoxic T cells will go on and attack what? Both of these structures we talked about. Myocardial cells and these valvulitis will be caused by affecting the valves. So you can see here, this is a depiction of it. This is a tricuspid valve. In bacterial endocarditis, mitral and aortic valve and tricuspid valves are affected. What about aortic valve? Now this is mitral valve, this is aortic valve. So in bacterial endocarditis, what she's saying is mitral, aortic valve and tricuspid valves get affected. Now this is very important. Mitral being the most affected valve. Aortic, less than that. Tricuspid, less than that. What's the only valve that's being forgiven, that's not being affected? That's pulmonary. So that valve is intact. Otherwise, Bacterial endocarditis led to mitral, aortic, and tricuspid valve, mitral, aortic, and tricuspid valve affection in bacterial endocarditis. In chronic valvulitis with stenosis or insufficiency, mitral and aortic valve and tricuspid valve, the same valves we talked about. Now, this was talking about acute condition. In acute condition, which valves are going to get affected? Mitral, aortic, and tricuspid. He's saying that in chronic valvulitis or with the aortic insufficiency or stenosis of some kind, and they are unable to open up properly, which valves are going to get affected? The same three valves. The same three valves, starting from mitral, going to aortic, then to tricuspid. Pulmonary, not being affected in these cases. Now, this is the left ventricle as depicted here, and this is the right ventricle, and this is the pericardium. And if there's any infection present, it will lead to pericarditis, and it will be inflammation. And that inflammation might lead to these organ dysfunctions too. It can affect the pumping activity of the heart. Now, next term we have pathology of acute rheumatic heart disease. Now, before I go on to pathology, let me tell you that any layer of the heart can get affected. It can be pericarditis, it can be endocarditis, it can be myocarditis, right? It can be any one of them. Myocarditis, pericarditis, endocarditis. All of those layers can be affected. Now, what we see here is that acute rheumatic heart disease, the slide, the histological structure, what will it look like on a pathological slide? Now, there are three identification points for you to find it in your mind, to save it in your mind as acute rheumatic heart disease, gross structure or histological slide. First of all, you'll see Aschoff bodies. Now, these are the most important identification point. These are Aschoff bodies. This is the number one identification point you have to pick up, right? Number two, now if there's Aschoff bodies, there's going to be anti-Ashkoff bodies. Remember that when there's Aschoff bodies is going to be Ashkoff bodies. They're called anti-Ashkoff bodies. Now they're present here, but they have this all eye appearance. You can see all eye appearance. You can identify it anywhere in any cell. Now in anti-Ashkoff bodies, you'll see all eye appearance. Now, as you can see, if you look at them, they're not flat, they're not, arranged in any kind of direction. But if we look at them like this, they look like caterpillar. They look like caterpillar. This is caterpillar appearance. This is caterpillar appearance. This is a third point of identification. Now, what's the fourth point of identification? The fourth point of identification is that it lacks the collagenous material. It lacks the collagenous material. Now, these are four important identification points for acute rheumatic heart disease and its histological slide. And it actually depicts the finding in them. So, what we're going to find in a slide of acute rheumatic heart disease? Aschoff bodies, anti-Ashkoff bodies, which have owl eye appearance and caterpillar structures if we look at them longitudinally. And number four, and the most important one, collagen material has been depleted or depleting yet, or still depleting. So these are the identification points that you have to go with when you're looking at a slide of acute rheumatic heart disease. Next term we have pericarditis. I just told you that any of these layers can get affected. It can be endocarditis, it can be myocarditis, it can be pericarditis. So what we just talked about, that was rheumatic heart disease. But what layer was that? Can you be very specific about it? What layer was that being affected? What layer was that? If we look at it. Exactly, it was myocarditis. It was myocardium, myocardial cells. So right now we're going to pericarditis. Now what is pericarditis? Inflammation of the pericardium is pericarditis. You can see this being the pericardium. Now look at it. Inflamed We talked about there are two kinds of pericardium, visceral pericardium and another one is diaphragmatic. What we call them is fibrous pericardium and serous pericardium. Serous pericardium being the inner layer or the visceral layer, and fibrous pericardium being the outer layer or diaphragmatic layer. So it has two layers, and if it gets affected, if it's being subjected to this kind of disease or infection, it might lead to pericarditis. And not in all the cases, but in most of the cases, it can lead to constrictive pericarditis. It's a very dangerous condition. We will talk about constrictive pericarditis in detail in another lecture. But what you have to remember this pericarditis can lead to constrictive pericarditis in some cases. Next on, we have acute rheumatic heart disease and its conditions. We just talked about those conditions, pericarditis and endocarditis. Now let's talk about both of them. Now let's talk about this comparison. First of all, in pericarditis, we have bread and butter pericarditis. What's bread and butter pericarditis? If those layers, it just wants to say, if those layers are separated, they give off this appearance of bread and butter, that if a bread was labeled with butter and two breads were combined together, and now if they're taken apart, now that inside appearance will be the appearance of pericardium. That's how it will look like. Bread and butter pericarditis. That's how it's depicted in books and texts. Next on, it has tenacious irregular fibrin deposits on the surface. In pericarditis, we have tenacious irregular fibrin deposits on the surface. What will those fibrin deposits on the surface do? They'll affect the myocardial cells. They'll affect what? They'll affect the valves. So more and more fibrous material will be deposited and more pathology will come out of it. On the other side, when we talked about endocarditis, it damages the heart and causes the focal loss of endothelium. When it damages and causes the focal loss of endothelium. On the same side, causes left side valves are more injured. Now, more injury on the left side damages the endothelium. And one more point is valve leaflets inflamed and edematous. Now, what's the comparison between these two? In pericarditis, we have bread and butter appearance. And yes, it does have a pathology. Yes, it's going to affect the heart. It causes the fibrin deposits and it causes the tenacious irregular fibrin deposits on the surface. And yes, it also causes that edema that we're talking about here. It also causes that edema, but not that markedly, not that visible, not that clinically affected. On the other side, we have endocarditis. In endocarditis, we have three very important ones. In endocarditis does affect, but it affects more on the left side of the valves. Why? Why it affects more on the left side of the valves? Because on the left side of the valves, heart is pumping more vigorously. Heart is pumping with more effort. There's increased blood pressure. When there's inflammation and edemation of these leaflets, what's going to happen if the blood pressure is more? More wear and tear will happen. We talked about it. When these valves are affected, now when they're inflamed and the blood comes in and strikes them and at a higher pressure and blood is trying to get out of it, it's putting all of its pressure on them. What's going to happen? More wear and tear. More wear and tear will lead to more wear and tear. And one way or another, it will lead to chronic rheumatic heart disease. So yeah, in endocarditis, we have more and more damage to the heart rather than pericardium or pericarditis. Next on, we're going to talk about acute rheumatic heart disease's clinical features. How a patient will present to you when he is suffering from acute rheumatic heart disease. What do you suspect that what patient will be coming to you? First of all, Jones criteria, no specific test. Now, what is Jones criteria? We're going to talk about it on the next slide. But Jones criteria is the basic criteria for checking for acute rheumatic heart disease. It's very important clinically. It's very important. You have to remember this name, Jones, and that's all. J stands for joint pains. O is mostly what we call P. J stands for joint pains. P stands for pericarditis. N stands for nodule formation. E stands for erythema marginatum. And S stands for superficial skin disorders. Now, this Jones criteria. Now, this Jones criteria we're going to follow. There's no specific test for Jones criteria. We look for these symptoms. We look for these effects on the body. Number 2, increasing serum antibodies to group A streptococcal antigen. Now, this is a very important marker even. Very important marker for the progression of the disease, for the progression of this kind of autoimmune disease, that how progressive the disease is getting, how progressive the disease is right now. So we check for the antibodies inside the serum of the person being affected. If the antibodies are more and more and more and it's increasing in size, that means either the antigen is present inside the body yet and still, or the body is hyperreacting. The body is overreacting to that antigen. When the body is overreacting, more antibodies will be produced. When more antibodies will be produced, more cytotoxic T cells are already in making. Both of them will go on and affect myocardial cells and the valves, and they'll lead to pathology. Number 3, symptoms begin 2 to 3 weeks after infection. Now, this is very important. We talked about it that yes, a throat infection comes in. Yes, a pharyngitis comes into the play. After the pharyngitis, what happens? It takes 2 to 3 weeks for this kind of autoimmune disease to trigger, for this kind of autoimmune disease to affect you. So it makes more and more antibodies, it makes more and more cytotoxic T cells. Both of those go to myocardial cells, affect them. It affects the sarcolemma, it affects the valves, it affects the glycoproteins. So it recognizes its own antigens, it recognizes its own body cells like sarcolemma and glycoproteins as foreign, and it starts acting on them, it starts competing them, it starts destroying them. And effects are acute rheumatic heart disease and many more diseases like them. So the point is, acute rheumatic heart disease is not just a disease, it's actually a consequence. It leads to mitral stenosis. All the pathologies that come with mitral stenosis are going to get there. It affects the aortic valve. What if aortic valve develops stenosis or regurgitation in some cases? So all the pathologies coming with aortic regurgitation and aortic stenosis will come into the play. It affects the tricuspid valve. All the pathologies related to tricuspid valves are going to get there. One valve that doesn't get affected is pulmonary valve. So symptoms begin after 2 to 3 weeks after the infection. Fourth one is recurrent group A beta hemolytic streptococci. Now either this happened, like recurrent infections happened, due to which more and more antibodies are produced, more and more cytotoxic T cells are produced, and they're going to attack those cells. They're going to attack that sarcolemma. They're going to attack that glycoprotein structure. And when this happens after 2 to 3 weeks, our symptoms start appearing. And increased serum antibodies to group A, streptococci, is a marker for infectivity, that this disease is progressing. More antibodies are being produced. They're going to attack the cells, and the more pathological consequences will be coming out of it. And then we have Jones criteria. Now let's learn about Jones criteria. What's Jones criteria? I told you already, but the point is that first of all, we have carditis. You can call it pericarditis. In some cases, most of the cases, carditis is pericarditis in this case. So for my sake, I remember pericarditis, but you can go with carditis too. Next one, we have chorea. In Jones criteria, we have chorea. We have erythema marginatum. We have polyarthritis. We have nodules. Now, how to remember this? how to keep it in your mind that these are the 5 major criteria for assessing or for reaching this diagnosis that this patient is suffering from acute rheumatic heart disease. First of all, the name Jones will give it away. J stands for joint pains. Now, this is polyarthritis. The J stands for joint pains. O stands for pericarditis. I remember is that pericarditis, you can go with carditis too. N stands for nodules will be seen on the forearm and the hands. E stands for erythema marginatum. And S stands for statendum chorea. That's it. Statendum chorea. In the previous slide, I said it's a skin disorder. I'm sorry, it's statendum chorea. So these 5 are the major structures. These 5 are the major consequence or consequelae of acute rheumatic heart disease. And this is how this is diagnosed. A patient will be suffering from all of these or at least some of these, and you will get to the diagnosis that this patient is suffering from acute rheumatic heart disease. Now, what examiners do, that they confuse you. They'll give you an MCQ like, oh, what among these symptoms or what among these conditions is not a major criteria? And they give you arthralgias. Now, arthralgias are not major criteria, they're minor criteria. What we have is polyarthritis, not arthralgia. So don't confuse yourself. Remember them as they are. So we have Jones. J stands for joint pains. O stands for pericarditis. N stands for nodules. E stands for erythema marginatum. S stands for statendum chorea. Now let's talk about the minor criteria. Those criteria that are going to confuse you, that the examiner would want you to confuse between major and minor criteria. What criteria are those? First of all, there will be a history of rheumatic fever. The patient will have a history of rheumatic fever. Patient already was exposed to this kind of environment, already was exposed to this kind of antigens. Body produced those antibodies, body produced those cytotoxic T cells, they affected the heart. Now, this is a minor criteria. Maybe that effect was not that prolonged, maybe that effect was not that lasting, but it was there and person got better and he has no apparent pathology or any kind of heart disease to be apparent. So, if the patient develops it again, this is the minor criteria. We can say, did you have any past history of developing this kind of rheumatic fever? And the patient goes like, yes, we have one of those minor criteria fulfilled. Next on, it should have history of arthralgias. Now that's what I was talking about. Don't confuse between polyarthritis and arthralgias. The joint pains, polyarthritis and arthralgias, don't confuse between them. This is the most confusing one between major and minor criteria. So there will be history of arthralgias. Why is going to be the history of arthralgia? If there was a history of rheumatic fever comes with arthralgia and minor criteria. It's going to have joint pain. It's going to have arthralgia. If there was any history of rheumatic fever, after it or during it, patient developed this arthralgia pattern. So, if the patient gives you history that, yes, I did have a rheumatic fever like 4 years ago, did you have joint pains? Did you have arthralgias? Yes, I did. 2 of these minor criteria fulfilled. Now, what's the third of them? Third is fever. Now, the patient will come to you with fever. Now, fever, you should be thinking fever should be in the major criteria. But we are not putting fever into the major criteria because it will just prolong the DDs. It will just prolong the differential diagnosis for you. So, fever, if fever is there, it means it's a minor criteria. It means yes, another criteria fulfilled. Patient is developing fever because the body is going through a lot of infection and the own cells are killing the own cells, and patient may have those active antigens inside the body yet. What's the fourth criteria? ECG changes will be seen. Now, what kind of ECG changes will be seen? It will be depending upon which structure is going to get affected. You might be thinking, what do you mean by which structure is going to get affected? Now, there's no per se ECG changes. There are no specific ECG changes. There are no pet ECG changes. That, okay, In acute rheumatic heart disease, we're going to have this. No, maybe acute rheumatic heart disease leads to aortic stenosis. We'll see aortic stenosis and ECG changes. Maybe it leads to mitral valve regurg. We'll see that on ECG changes. So it depends on which valve got affected, on how much level, and due to that valve insufficiency, due to that valve stenosis or regurgitation, which of the heart structures are going to get affected, which of the cardiac cycle is going to get affected. So ECG changes are very variable in this case. You don't have to dig into them. What you have to know that ECG changes will be according to the pathology coming out of acute rheumatic heart disease. Next on, we have laboratory test. We'll go for the laboratory test. First, one test that we talked about, that we go for antibodies against the antigen. If they're booming, if they're increasing, it means the patient is already in active disease. What's going to be the treatment? I think you should be very much aware of the treatment right now. So for getting to the treatment, it's not like you have to memorize everything. It's not like you have to be like, okay, acute rheumatic heart disease, what was the treatment? No, just think about it. What are the pathologies that are going inside in this disease? What are the pathologies that are leading to this? What are the pathologies that are occurring, that are happening inside this disease? We have to stop them. We have to stop them at some level, and this won't be affected. So what are those pathologies that are happening? First of all, inflammation is happening, right? Inflammation is happening. Inflammation is happening at what level? All the valves are being inflamed, right? So we have to stop inflammation so that it won't get too inflamed and so that they can perform their function. So we have to give some anti-inflammatory. And second, what we have to do, immune system is killing our own body. So what we have to do is put a stop on the immune system. Ask the immune system to, okay, just shut down, will you? So what antibiotics or what kind of drugs will be given? Corticosteroids, right? Corticosteroids are the most potent immunomodulators. In any kind of autoimmune disease, we give corticosteroids, they weaken the immune system and the patient gets better. So we give two drugs. First of all, corticosteroids to modulate the immune system, to take it down, that it won't produce any more antibodies and cytotoxic T cells, to kill its own cells, to kill its own sarcolemma, to kill its own glycoproteins. And what other effect will be coming in by salicylates? Now, salicylates, what's the example of salicylates? I'll wait. What's the example of salicylates that you read every day? Aspirin, right? And aspirin is what? If you read pharma with a lot of concentration, what aspirin is? It's COX-2 inhibitor. What do you mean by COX-2 inhibitor? That it's going to stop the inflammation from happening. And if the inflammation is stopped, now both of these pathologies can be stopped with these drugs. Salicylates will stop the inflammation. They're anti-inflammatory. So inflammation is stopped. Now, if the inflammation is stopped, now those valves are going to affect normally. Then they're not being affected, they're not being inflamed more than that, more than what they were at that stage. And at the same time, cells that were killing them, cells that were affecting them, they are being taken down by corticosteroids. Now, this is a perfect regimen. Now, this is a perfect treatment for this kind of disease. We took down the two pathological consequences. We took down the two basic consequences that led to many pathological consequences and nipped them in the bud. And that's how we treat acute rheumatic heart disease. Now let's talk about chronic rheumatic heart disease. What's the pathology there? What's the pathology that led to chronic, that led from acute to chronic? So chronic rheumatic valvulitis. This is what the chronic rheumatic valvulitis will look like. But before we go on to chronic rheumatic valvulitis, let me ask you that what conditions led from acute to chronic? Number one, we didn't use the medication. We didn't use the proper treatment. We didn't take out or take down the immune system. We didn't stop the inflammation from happening. So We didn't stop it. We didn't intervene. Number one point. Number two, it was repeated exposure of that antigen. If a patient is getting this disease from some source, is not moving, is not going away. That source is already there. So the patient is getting again and again and again, and more antibodies are produced, more antibodies are produced, more antibodies are produced, more cytotoxic T cells are coming in to kill it. So, second point is repeated exposure. Number three, those patients which had weak immune system. Now this is a tricky one. Weak immune system, they got this disease, but that even weak immune system is going to kill off its own cells. So due to these three conditions, an acute condition leads to a chronic condition. We didn't treat it. Exposure was multiple times. Exposure was again and again and again, and immune system was not up to that mark that it could contain it. Mostly, it happens in those patients who are already suffering from autoimmune diseases. It doesn't happen in every person who's not fit enough or healthy enough. If you have to compare between patients who have good immune system and patients who have bad immune system, patients with good immune system are going to get it more. They have more chances of developing this disease. So when all of these three conditions are not met, what happens? If the exposure, if the effect is continuous, the chronic, the valves are being affected chronically, what's going to happen? Chronic rheumatic valvulitis will come in. And chronic rheumatic valvulitis, what will you see? Calcification. You can see calcification will be seen. Now, this means it's very tricky. If it's calcified, it should not move properly. It's not moving properly. And if it's not moving properly, it's not doing its snap. It's not doing its flip flap. Now, if it's not performing its function, now if it's not opening at the perfect time, if it's not closing at the perfect time, it will lead to arrhythmias. It will lead to pathologies of the heart. So the chronic rheumatic heart disease is very, very consequential. Next on, we have chronic rheumatic heart disease pathology, that if chronic rheumatic mitral valvular disease happens. Now, this is a photo taken from a heart which has been affected by chronic rheumatic heart disease. It's the mitral valve disease. This is taken from the aortic level, and this is taken from the ventricle cross section. Now, what you look at is that they are calcified, they are stenosed, they are narrow, they have fish mouth appearance. What the word you'll hear from the examiner, the word you're going to read in the MCQ, the word you're going to read in the text is fish mouth appearance. You will see fish mouth appearance in mitral valvular disease and chronic rheumatic heart disease. This is what it looks like. It has been constricted. It was like this before, now it's like this. It has been constricted, it has been calcified. Now, it's not up to that mark to close and open in a snap. It's not up to that mark to do its function properly. So, it's going to get more and more affected. It's going to get more and more pathological. And when the blood, even the oozing of blood, that blood comes out of it is very difficult, it will lead to pathologies and the consequential diseases that come with it. Now, what happens if it's aortic stenosis? We talked about mitral. So, mitral was the valve being most affected. What was the second valve that was being most affected? Aortic valve. And what was the third valve being most affected? Tricuspid valve. Which valve was spared? Pulmonary valve. Now, chronic rheumatic aortic valvulitis. What you will look like on this slide, what you will look for in this slide is this. You can see very narrow calcifications happening. It's calcified, it's not up to the mark. In most of the cases, you can see this is the case which has happened due to aortic stenosis, and this also might lead to the formation of aortic regurgitation. Now, I think all of you know the meaning of stenosis and regurgitation, right? But still, I would like to explain it in case someone has forgotten about it or is new to this terminology. Now, if we have a hole like this. Holes being these valves that we're talking about. Now, all of these valves are actually guards. They protect the blood in and out way. So what we have to do is we're going to draw some diagrams for you to understand it properly, the concept of stenosis and regurgitation. Now, for example, this is aortic valve. Not aortic valve. Valve will be here, trying to guard it, trying to maintain its outgoing and stoppage and ingoing. So it's actually a guard. It snaps open, gives all the blood away, then closes back. So what happens if it gets stenosed? What will happen in the case of stenosis? In the case of stenosis, these leaflets, these will be affected. Now, when they will be affected, now the hole which was being produced right here, now if these are being affected at a very major level, what will be the appearance of it? Now, let's see what will the appearance of it be on a pathological slide. This is what it will go on. This is what it will go on to look like. Now, what does this look like? Fish mouth appearance. We talked about it. This will be fish mouth appearance because it's being pulled from here, it's being pulled from here, it's being pulled from here, it's being pulled from here. So the size of that hole goes down. It's fish mouth appearance, a lot of blood has to come out of it. So one way or another, it will lead to pathological consequences. So this is stenosis. In stenosis, due to calcifications of these, due to calcification of all of these structures, the size of it goes down. Now, what's regurgitation? Regurgitation meaning that if the blood is coming out and that hole, which was supposed to be this big, is now this big, and due to this, it has lost its elastic power to come back to it, to come back to its normal shape. It's even open in its diastole. It's not in systole, okay, it's open so that blood can go out. But even in diastole, it's not being closed. It's not going to close. It stays open up to some extent. It stays open up to some extent, even up to this extent. So what will happen? The blood that was supposed to go down, the blood that was supposed to go out of it, some of it goes back. That's called aortic regurgitation. I hope you get the point. In stenosis, our opening is narrow. In regurgitation, our opening is too wide, and even in the closing of that valve, it's not completely closed, and some of the blood goes back. That's all about it. Next on, we have chronic rheumatic heart disease complications. What complications come with chronic rheumatic heart disease? First of all, we have mural thrombi. What is mural thrombi? It's actually a thromboembolic phenomena. It's actually a thrombus. So when a patient is suffering from chronic rheumatic heart disease, what happens is that patient develops this thrombus, which is attached to its wall, which is attached to its atrial wall, and it's hanging down. It's hanging down. Mostly it happens in left side of the atrium, and it's hanging down, and in some cases it blocks the mitral valve. It blocks the flow of blood from left atrium to left ventricle. That's what mural thrombi is. It can even lead to very pathological consequences in case of a complete blockage. So, in chronic rheumatic heart disease, mural thrombi can develop, which is attached to left atrial wall from the inside, and it's blocking the mitral valve opening and not letting the blood from left atrium, left ventricle go. Next on, we have adhesive pericarditis. Now, adhesive pericarditis is a condition in which pericardium layers are adhered to each other. It can be with heart. If pericardium is attached to heart, if it adhered to heart, it's adhesive pericarditis. Or it can be anything which is close to pericardium. It can be with other structures too. So adhesive pericarditis develops in this case. Next on we have bacterial endocarditis. How does a patient from chronic rheumatic heart disease leads to bacterial endocarditis? For example, a child of 9 to 10 years of age has reported with this kind of pathology, has reported with this kind of dilemma that that patient has developed acute rheumatic fever. Now, if the patient is already suffering from acute rheumatic fever and afterwards that patient went for a dental procedure, when that boy or that patient went for dental procedure, that patient or that boy has exposed himself to the bacterial antigen, so the bacterium. Any bacteria now can get inside, and with the immune system even acting against its body, now these are the most favorable conditions for bacterium. And out of all the structures in the body, bacteria are going to go to mitral valve, to aortic valve, to tricuspid valve. Those valves which are already affected, those valves which are already under the scrutiny of the immune system. Now they find their most favorable environment in those valves, and they start progressing there, and that will lead to bacterial endocarditis. So bacterial endocarditis comes into the play right after acute rheumatic heart disease. But in chronic rheumatic heart disease, if the patient is suffering from it and not getting better, now the immune system is already down. All you have to do is expose yourself to the bacteria and you will develop bacterial endocarditis. And it's rather easy for bacterium to cause bacterial endocarditis in chronic patients because now their valves are affected so badly that even very minute exposure may lead to bacterial endocarditis. Next on, we have congestive heart failure. Now, how can we say congestive heart failure? Now, when the valves are being affected, the blood cycle, the whole cardiac cycle is being affected in one way or another. If there's aortic stenosis, more pressure will be required by the left ventricle to push the blood out of it. Left ventricle hypertrophy will come in. Left atrium will get affected. Pulmonary vasculature will get affected one way or another due to any valve insufficiency or problem. So it's not just one pathology, it's a consequences of pathology. Any pathology may lead to other pathology, then that pathology will lead to the other pathology, and it will go on up to the chain of command, and that will lead to congestive cardiac failure. Next on, we have autoimmune diseases and how they're attached to these our valvular diseases. First of all, we have SLE, systemic lupus erythematosus. Now, this is an autoimmune disease which causes Liebman sac endocarditis. Now, you must be thinking it's endocarditis must be bacterial. No, it's the only endocarditis which is non-bacterial in its origin. It's non-bacterial. It solely happens when in SLE, in systemic lupus erythematosus, antigen-antibody complexes are formed. Now the body is killing itself. Now when the antigen-antibody complexes are being formed, they start to deposit inside the heart and they lead to Liebman sac endocarditis. It's non-bacterial in its origin. It's non-bacterial. I hope you get that point right. It's non-bacterial in its origin, and it affects basically which valves? It affects basically mitral valve, aortic valve. And this happened in SLE. And when you look at a pathological slide, this is how it looks like. You can see hypercellularity. You can see non-infectious kind of endocarditis. Non-infectious kind of. You won't see like eosinophils, neutrophils, all of those cells are coming in to kill the bacteria. No, it's antigen-antibody complexes that are being deposited, and that is leading to this kind of endocarditis. Next on, we have rheumatoid arthritis. So the question we're going to ask is, can rheumatoid arthritis lead to rheumatic fever? So what's the answer? Rheumatoid granulomatous inflammation will lead to fibrinoid necrosis and palisaded lymphocytes, meaning these are the consequences of it. Very minute chances of it happening, still there are. So rheumatoid granulomatous inflammation will lead to fibrinoid necrosis, meaning necrosis is happening, which is fibrinoid in its nature. Fibrin is being deposited, cells are being necrosed, and palisaded lymphocytes, and this will lead to cardiac effect. This will lead to cardiac effect, but cardiac function remains intact in all of this pathology. Yes, it goes on. Yes, it goes on and affects the heart, but the cardiac function remains intact. It the extent of its damage is not that much. All it does is that this granuloma formation that happened in rheumatoid arthritis will lead to fibrinoid necrosis of that place and palisaded lymphocytes, but it won't affect the heart that much. It won't affect the heart in its working capacity. The heart will be working properly. The heart functions will be intact. Next on, we have ankylosing spondylitis. This is the only pathology, I suppose, in which you just look at it and you say it's ankylosing spondylitis. So in ankylosing spondylitis, which is also another autoimmune disease, typically aortic valve lesions develop in 10% of the cases. In 10% of the cases of ankylosing spondylitis, aortic valve stenosis develops. So it's not basically stenosis, it can be any one of them, but mostly a lesion in the aortic valve develops in ankylosing spondylitis. That will lead to dilated aortic valve ring and cusp scarred. When we learned about regurgitation and stenosis, when I was showing you the diagrammatically approach, so what I told you that these cusps are scarred. Those cusps which were they attached to are scarred now, and they are dilated. There's nothing to pull them back. There's nothing to push them in. So now they're dilated. Those aortic valves are dilated. So focal inflammatory lesions in aortic valve will come in. Now, all that inflammatory effects are coming in. Now the body is reacting to it. Now they're going under inflammation. And that will lead to aortic regurgitation as a consequence. So what happened in this case is that typical aortic valve lesions occur, which happen in only 10% of the cases. Not every person, not every patient who is suffering from ankylosing spondylitis will get aortic regurgitation, but 10% of the patients will get it. Because it's an autoimmune disease, it can just focus anything. Out of the whole body, it can focus any cell, any tissue. So in 10% of the cases, the tissue that's being affected or focused is aortic valve. When lesion develops, it leads to scarring of the cusps. It leads to dilation of the aortic valve rings. When they dilate beyond their point of dilation, what happens? They don't come back properly. I told you in regurgitation, they don't close properly because of this cusp scarring and aortic valve ring dilation. So focal inflammatory changes will come in. They'll do more damage. They'll do more wear and tear, and that will lead to aortic valve not even closing properly. And when it will not even close properly, the blood that goes out of it, some of it will come back eventually, and that's what's called aortic regurgitation. Next on, we have scleroderma. Now, patients suffering from scleroderma are going to get this disease. 60 to 70% of the patients who are suffering from scleroderma are going to get myocardium with sclerosis. The sclerosis of the myocardium will be happening. You can see sclerosis of myocardium will be happening because the major organ being affected in scleroderma is heart. So sclerosis of myocardial layer will come in. That will lead to arrhythmias. And those arrhythmias may lead to congestive heart failure. Next on, this will develop cor pulmonale, and finally it will lead to hypertensive heart disease. So what I have to tell you what cor pulmonale is, do I have to tell you that we have a whole lecture on cor pulmonale? You can go back and watch that. But for now, for this point of view, I'm going to explain it to you. The myocardium, which goes into sclerosis, will lead to arrhythmias, because if myocardium is sclerosed, if some part of the heart is not working properly, what's going to happen? The heart, which was working as a unit, that was pumping as a unit, now some parts of the units are not working properly. They're not working as a unit. When they're not working as a unit, arrhythmias will happen. Some parts will contract before the time, some parts will contract after the time. That will lead to arrhythmias. And those arrhythmias may lead to congestive heart failure. When congestive heart failure is happening, what's going to happen? Cor pulmonale. Cor pulmonale is what? Right ventricular hypertrophy due to systemic hypertension or secondary kind of hypertension, which happens due to pulmonary vasculature. So cor pulmonale will come in. Now, after cor pulmonale, hypertensive heart disease is also seen. When cor pulmonale is happening, obviously it will lead to hypertensive heart disease. So these are the consequences of scleroderma. Starts with myocardial sclerosis, goes to arrhythmias, congestive heart failures, then leads to cor pulmonale, and then finally leads to hypertensive heart disease. But hypertensive heart disease are seen in some cases, not all the cases, but up to the cor pulmonale, it's the same journey. Next on we have polyarthritis nodosa. What polyarthritis nodosa is? It's actually systemic vascular necrotizing condition. It's actually systemic necrotizing vasculitis of the medium-sized arteries, not small arteries, not large arteries, medium-sized arteries. So what it does, it leads to the necrosis of the medium-sized arteries. So what if it affects the coronary arteries? When the coronary arteries will be affected, heart won't get enough of the blood supply, the heart will lead to myocardial infarction. Now that myocardial infarction, if treated at proper time, even if given treatment, that will lead to arrhythmia. Now some part of the heart did not get enough blood supply, that part of the heart is dead. Now that part of the heart is not working as a unit. Now that part of the heart is not working as a pump. If it's not working as a pump, it's not helping the heart doing this. It means that part of the heart is dead. Now, if that part of the heart is dead, maybe some part of it's functional and it's contracting later than before or with the whole structure of the heart. So this kind of abnormality will lead to arrhythmia. And after arrhythmia, what comes in? Heart block can come in. Heart block can come in due to the narrowing of it, due to the necrotizing nature of it, due to any kind of thromboembolic phenomena. Now that heart blocks will come in, and somehow due to all of these structures will lead to cardiac hypertrophy when the heart has to pump more and more blood with more and more pressure. That will lead to heart hypertrophy. So what we learned in this lecture is that how our own immune system is the culprit for causing all of these pathologies, for affecting the heart in that way. It starts that the foreign material did come in acute rheumatic disease, but what happened afterwards? Our own immune system identified our own cells like sarcolemma and glycoprotein and started destroying them. And in the same way, we have ankylosing spondylitis. In the same way, we have systemic lupus erythematosus. One way or another, they lead to the pathology of the heart. Mainly, they affect those three valves. You have to remember mitral valve, tricuspid valve, and aortic valve. So they affect these valves. They cause all of these pathologies. What we can do, what we can hope out of intervening is that we start immunosuppressants like corticosteroids or other immunosuppressants, and we expect that immune system will go down and it will start acting against its own cells. On the other hand, what is a symptomatic treatment? For example, in acute rheumatic disease, we have inflammation. In rheumatoid arthritis, we have inflammation. So we treat the inflammation by giving anti-inflammatories. So that's how we treat the autoimmune diseases. We don't have the proper treatment for them. We give them immunosuppressants, we give them immunomodulators, and this goes on and on and on. So that's all for today. Thank you for watching.